All right, bridging the gap between research and policy. Joining us in the hot seats of the Situation Room this morning, Jeremiah Nganda is an ideal postdoctorate fellow with Strathmore University. They'll tell us what ideal is in a moment. Noella Orata is an ideal PhD fellow at the Strathmore University, and we're going to talk about bridging the gap between research and policy. Strap up, because it's going to be an interesting one this morning. Good morning to you both.
Hi, good morning.
Good morning. How are you doing?
Doing well. How are you?
Very well, thank you. Karibu sana.
Thank you.
Asante sana.
So, to get you into the hot seats and all wrapped up and comfortable, we normally take a trip around the African continent every week. We come back from one country and CT normally gives a proverb from that country, which we will then give you the responsibility, nothing like putting you to work early in the morning, of interpreting that proverb for us. Mark, who has been delegated that responsibility, will tell you what that proverb is, and then you can tell us what you think about it. All right?
Well, the country we are talking about, if you know the president of that country, will give you candy to make the hot seat.
Who will give you candy? Oh, you.
Yes. So, this country once had a president called Muammar Gaddafi. He was very famous.
Oh.
Can you tell us the current one? That's not the question. I'm joking. Yeah. But I'm sure Ndu, it's that guy's name is very hard to say, and there are two. Yes. But wahenga wao, their old men used to say that he who keeps the company of a dog will bark.
Wow, that's
Interesting.
yeah, that's really an interesting one. And one of the things about our proverbs, you actually feel like most of them actually are very related. Yeah, and I think it's simply the company that you keep, you're going to end up having the same behaviors as of those who you keep their behavior. Yeah, the same way the Bible would say that bad company spoils good morals. So I think it's the same way. If you stay with people that have this certain kind of a behavior, you will end up actually adopting the same behavior. That's, I think, in my view, is how I would look at it. I don't know that Dr. Noel would want to see it from a medical perspective.
Yes, you become who you're with, right? So, from a intensely medical perspective, if you were eating healthy, and then you're hanging around people who are eating unhealthy, inevitably you're going to change your diet. So that's my take on it.
Interesting. But it's always interesting to me that the dog never learns to speak.
When it's hanging around people.
Yes.
Yeah, well. Okay.
Just a spanner.
It's the same thing. Like, a dog can bite a man, but a man is not going to bite a dog.
No, it speaks, but in a language you don't understand.
Yeah.
Oh, yeah.
Well,
People are called dog whisperers.
yeah.
They communicate with dogs.
True. But I'll remind Ndu that in China,
Here
dogs,
we go.
dogs do get bitten.
Okay. Well, I'm glad that we had interpretation for that proverb. Mark Buchachi notwithstanding.
Yeah.
All right. So, we're looking into research and policy. Interestingly enough, looking at some academia in the morning, we were talking earlier in the morning, rather, and we're talking about, the need for institutions of academics to actually be not just thought leaders, but implementation leaders and examples for nations that can actually wield unbelievable things, because we've seen it happen around the world. Now, when we talk about research onto policy and then its implementation, that's where we seem to suffer a little bit here and there. But before we get into that proper, which I'm sure we will during this conversation, we're curious as to what ideal is, because both of you are fellows, literally. Ideal fellows. What is that?
Okay. The ideal is the initiative to develop African research leaders. Under this body, we have quite a number of organizations or partners. We have the Center of Infectious Disease Research in Zambia, F Center in Niger, and then we have Strathmore University in Kenya. We have Pwani University also in Kenya. We have the University of Glasgow, and also we have the Oxford University in the UK. These partners are focused on, just like the name says, developing African research leaders. The thinking is Africa needs to solve its health problems. And the way it can do that is by having researchers who are well trained, who are skilled, and who are motivated for them to be able to address these issues. So under the ideal program or the initiative, we have mentors, we have fellows, and also who mentor us now into getting into real research. We are offered opportunity not just to do the research, but also to participate in seeing how this research, the findings or the evidence, gets into the mainstream and supporting decisions, policies, and practice that we are seeing in the real world. That is who Ideal is. And when you look at Dr. Noel, you can tell she's really motivated. So this is what Ideal really aims for. Yeah.
So what kind of work do you do? You as a PhD fellow, what kind of work do you do towards this initiative?
Yeah, so I come in as a student, attached to Strathmore University here locally. And basically, we're then thinking through context-specific health topics to then champion the Ideal initiative here in Kenya. Myself, I'm doing something around public-private collaborations. So we know that Kenya moved from being a low-income country to being a low to middle income country, meaning we're seeing a lot of, funding moving out. I think the idea is we are now teenagers and we can fend for ourselves. And the idea is we need to begin to think about not waiting for aid, but beginning to trade in everything that we do. This has, significantly impacted the healthcare sector with, declarations we've heard from other governments. But I think Kenya it's time. We need to rethink how we've been doing healthcare in this country, including funding.
Yeah.
And one of the avenues is actually public-private collaboration. So how do we bring in the efficiencies in the private sector and, the scale and the population in the private sector so that we better their healthcare?
Right.
So the importance is that we need data for these decisions. This is where research comes in. It's not ad hoc. It's not assumptions. For example, we really need for example, the census. How many are we actually planning for? And what does it take? So then we bring in the research to intersect and, tell the government, this is the data, and this is how you can plan around finances.
Right.
I think healthcare is also very unique because we intersect with probably every ministry in this country. We intersect with water, right? We intersect with food and security and nutrition because it affects health. The justice system, So figuring how do we plan, in a multi-sectoral, multidisciplinary approach to then figure out healthcare.
How this okay.
Yeah.
Now, when we think about research and we think about healthcare, our friends at KEMRI then also come, front and center here. Kenya Medical Research Institute, when we look at things like malaria, when we look at things like sickle cell, when we look at COVID, when we look at really any major healthcare almost crisis, that KEMRI was at the center of sorting out the data that you speak about behind it, the research into some of these things. And the question then is, how has that and those collaborations gone towards making sure that we see the importance of research and that data towards solving some of the crises that the country then gets into in the health arena?
Okay, well, thank you. That's a very good question, and I totally agree with you that KEMRI has been on the forefront. And when we come to Ideal, it's hosted by KEMRI and Wellcome Trust. And what these two partners do is they create the avenue for the researchers and the fellows who are within the Ideal project to be involved within some of the processes that are meant to influence policy within the health sector. For instance, I will share my experience because of the KEMRI Wellcome Trust partnership. I was seconded to the presidential task force, the one that was chaired by Professor Kamarogo, and was seeking to address human resources for health challenges in the country. I joined them as a technical expert purely with the intention of having experts involved in this process and in not influencing but contributing to the kind of outcomes that we are seeing within the health sector. Currently, I am part of the technical working group that is seeking to operationalize the Kenya Health Human Resource Advisory Council, which also is going to be in the forefront in addressing issues that have been facing our human resources in the country. We are talking about the interns, talking about the specialists, talking about the healthcare professionals, talking about all those issues that are related with data for health human resources. So under KEMRI, we are equipped, or we are provided with the avenue for us to be involved in these processes. One of the major tasks that we've done towards the operationalization of the Kenya Health Human Resource Advisory Council is to do a policy environment analysis. So we go deep into analyzing all these health policies. We look at what are the major issues, what are the gaps that are currently existing, and then from those gaps that we have identified, together with the other members of the technical working group, they now proceed to coming up with solutions on how to address these gaps, these challenges, in a way that is evidence-informed. So that, from my experience, is what I would say we are doing, directly linked up with what KEMRI, Wellcome Trust, and IDEAL are involved in.
You know, when you talk about, you've talked about KEMRI partnership. I had a conversation with a scientist some time back, and the concern this scientist was raising with me is the fact that through the years, we seem to be having a decline in a budgetary allocation for research in this country. And I keep talking about this thing of what are our priorities as a country. I'll read something interesting here. And my concern is the allocation that goes into, for example, KEMRI, all right? So despite the government's commitment to keep increasing, there was a budget that was given in 2024 national budget, which was 3.05 billion. Now, this comprised of 2.51 billion for recurrent expenses. Then you have 537 million for development projects. But guess what? Only 400 million was going to research. Only 400 million. Now, when you look at the commitment to fund, a lot of the partnerships are coming from outside.
Yes.
They're not from within. So my question then is, why do we see continual gaps in terms of funding or the prioritization of research in this country?
Maybe, yeah. I think one of the things is there's been a disconnect between academia, policy, government. So I love how the Dutch government actually runs their healthcare. So there's the public sector connected to the private sector, academia, and then research. So academia in this case would be the training and capacity building of these healthcare workers who are going into it. For us, I think academia has been very isolated. We don't talk to the community. So we don't even speak the language because we make it so complicated it's not relatable. And that's been a problem. So I'm sure there's, when I think about what you're saying, there has been, I'm sure there was, reasoning and justification behind that. But for me, forward thinking, here is where we are. Are we thinking about alternative funding mechanisms that are not traditional, that can still enable us to do and go about our research? So, when you were talking to Jeremy, I was just thinking about the COVID era and how KEMRI was so important. So at the time, they were actually putting out position papers, which were very important to ministry when they were making the decision. So, they were doing a lot of testing, including surveillance, where is the density areas, which I think at the time also informed, the lockdown at the time and all these policies and, guidelines and that they instituted and put into place to guide us. I remember as myself, I'm a consultant pathologist. I actually chair also the Kenya Association of Clinical Pathologists. In our space, we are predominantly in the lab, and we also do forensic medicine. And I'm sure you're aware that at the time there was a policy that came out from government that we're barring within 24 hours. I think it was very nice because the government actually called us to the table as professionals and peers and said, can we work together to see how to look at this? Now, in the association, of course, we have those who are coming from academia and they're doing research aware of all of this. I think in the background of it was, Ebola and what happened in Sierra Leone, right? Because we know Ebola is a very hemorrhagic virus, and when you touch it, actually gets transferred. So that was, I think, part of their thinking and their worry around it. And at the time, we did see a lot of mortalities pegged to that. And we also know, as scientists, maybe something I can educate the public is when a person who is deceased may have died of TB, the people handling the TB could actually get it, the people who are handling that. And so I remember there was very high-level stakeholder consultation with religious leaders trying to see what is feasible for everybody and acceptable culturally with regards to this new institution, that policy that was going to be put into place. So I always think that number one, academia is very far removed from what is happening with community. So maybe we need to develop multi-stakeholder, multidisciplinary coordination committees to think about what does the community want. I think in other sectors we see a lot of public participation. For healthcare, I know it's done a lot in research. Actually, it's required in research, and we have very robust consent forms to get to that. So just going into your financing on research, I think maybe we have not actually tooted our horns enough to show you that actually a lot of the decisions that are made are because of research.
Isn't that the problem, though, right there?
Yeah.
That where we see some of these things happen that you spoke about before, is that the folks who work on the communication end of things, they make it their job night and day to toot the horn about this thing that happens. That without that information in the out there, that nobody is going to know. These are fundamental things that happened, for example, with COVID. That it is actually something that the world paid attention to parts of Africa and said, hang on a minute, how come these folks are not dying the way we thought they were going to? Look at the surveillance that happened as a result of the research that was done and the data that was collected.
Absolutely.
And then they were able to inform communities and say, you know what? Social distance, wash your hands, and wear a mask. This is we want to say that it's simple, but that is actually policy.
Yes.
Right? And it's implemented so much so that people then are careful. What happens with things like cholera, that people understand that, water bodies that are infected, you should stay away from them. It becomes policy. But then it is isolated, and the people who are doing this research, the doctors, the Noelas, the Jeremiahs, the Sophies who are in Kilifi, those who are doing this remain in the lab.
Yeah. So I think from a public health perspective, it has turned around. I think, we have this new cadre called the community health promoters at the moment. And I think personally, I've had stories where they've been very, very useful in actually reducing the cholera spread, for example, in high-density population areas. So you must give it to them. I think that's coming from a place of science and, the government thinking about how do we then intersect science with protecting the community. A lot of these initiatives, of course, went into public health, and they actually translate. So, I'm even thinking about recently, the polio vaccine hesitancy or resistance from the community. Is there room to improve? There's always room to improve anything and everything. And so, yes, part of bettering the communication is us coming to this show and showing that, the science we're doing actually does translate and influence care and patient management. I think, medicine comes with many things. There's a promotive aspect, preventive aspect. It's just that maybe in this country we've predominantly focused on the treatment aspect, which probably maybe 15% of the population, but the healthy 85%. Kenya, we are a very young population. We need to talk to them, and research is actually very useful.
Let me tell you why. If I circle back to the funding question, I'll tell you, because you've talked about the hesitancy with the population when you talk about polio. If we go back to COVID, the conversation around vaccine, and we all know that's a rabbit hole if you go there. The issue of funding for me is the over-reliance on external funding for research initiatives always ends up having this ripple effect on who is behind the funding. What are their motives for pushing this vaccine, for pushing this kind of research? Why are we doing this? And so you find the pushback then is we don't feel we own this. This is research done by our own people, finding our own solutions. But they're influenced by the people who are actually funding.
Yeah. I totally agree with you. And we are coming from Ideal, and we are saying part of our partner is Welcome Trust, which is actually a development partner who is not local. We are making baby strides in terms of creating an appreciation of research in practice and policy making. But the truth of it is, as we stand right now, we have a low uptake of research in our country.
Why?
The only time we get to hear a lot about research is when we are doing the opinion polls towards the general election. That's the time we'll talk about all these research organizations. But when we're dealing with health issues, with health systems, we hear very little of research. We are generating a lot of evidence in terms of research, but I feel as researchers, we keep on communicating this within the academic circles. We have our conferences where we'll go as researchers. As academicians, we will share our findings.
I want to ask you something. It's itching,
Yes.
I can tell. We're going to go to a break in a minute, but this is the thing. My understanding of research is that it is to find an answer for a problem that exists in society. Yes, it's people are not just sitting up in the morning and saying, well, I think I'm going to research about what the female mosquito looks like. No, something that mosquito did is causing a problem. We need to find out what it is there to solve a problem, right?
Yes.
The people who are doing the research in Kenya, for example, pathology, the people who are doing the research in Kenya, sickle cell, malaria, are they Kenyans?
Yes.
So maybe
Yes.
I can add on to that.
If that why then is it not being taken up? If it is answering questions that exist here for problems that are prevalent here.
Okay.
Yeah, I think sometimes I'm afraid that we can oversimplify research. Research is a very robust, very ethical process with declarations made out of the countries and globally that we all, as Kenya, adhere to. Research actually is tailored towards our context. Even as we begin the process, we always come to the table together as teams. I also know that there's been a shift globally where initially, I think like you have rightfully said, there was a tendency where it was sort of dictated to us. Kenya has come a long way, and one of those that we really love is the Data Protection Act, actually, which is now enabling us to first maintain our data because, it then looked like all our data was going out there. So we're able to protect our data. But when we are starting the research process, you find that all the parties come to the table. And we are able to say, you know what, in our context, whatever you're trying to tell us doesn't work. Then as scientists, we think together, okay, so what does work in our setting? Even as we start the research process, there's a whole community engagement. Ideal is actually very well known for that. KEMRI has a robust community engagement process, which is actually what brought us here. And we're able to educate the community about, there's this research incoming. Are you okay with it? Are you happy to embrace it? And what aspects do you want changed in it, right? Before we come. And we share the tools and we explain thoroughly what the process is going to be. And for the individuals who are involved in the process, because like you have rightfully said, it may be sickle cell patients. So we call them sickle cell warriors. I'm involved a lot in the sickle cell space. The reason we call them warriors is that it's a chronic disease. They're fighting for their life, and lifetime. And so they're warriors, and we're striving to achieve wellness. It's not just disease-free. We want them to be well, to have full lives. So we have this engagement segment. The other thing that we're also required to do once we do research is the first thing we're supposed to do, and this is a standard research protocol, is you must share your findings with the stakeholders that were actually involved in that process. I think it's done at a small scale. So even malaria, a lot of it in our setting, although there's a whole belt across Africa, we're actually supposed to go back to the communities and share our findings and tell them, we need mosquito nets. Wash your hands and get rid of pools of water because that's where, mosquitoes thrive and you get this organism, Plasmodium. So I think there's still an intersection. Is there room to do more? Absolutely.
Sure.
There's room to do more and share with the community and explain. Yeah.
Okay.
Yeah. I wanted to just add something on what my colleague Dr. Noel has said. And when we look at the research that we are doing, I feel we have a weakness, so now we are communicating this evidence, especially to the policymakers. We need to have supply of credible research. And beyond, if you go to any of our institutions right now, you're going to see volumes of dissertations and theses that have been done, bound and kept in the libraries. But are we packaging these findings, this evidence, in a way that it makes sense and is easily digestible by the policymakers.
Sure.
We are failing in that front. But then also from the side of the policymakers, I think I would say we need to build their capacity to be able to use research, to use evidence to make some of these decisions that they are making. So for me, I think we need to think about the supply of credible findings and a constant engagement between the researchers and the policymakers. But also at the same time, we also need to build the capacity of the policymakers in a way that they're going actually to be demanding for these results. And that's what I was saying. We are making baby steps, but we are not where we should be as a country. When you compare with some of the countries outside there, the likes of Germany, the likes of China, they rely a lot on research, on evidence for any of the decisions that they are making. For our case, I think it's totally different, but we will need to move towards getting there.
Before we go into other questions, coming off with the concern, we're not making decisions based on research and data that has been collected. But everybody knows that we should. So why?
A very interesting question you ask me. And it stems, I think, from our low appreciation of research and a tendency for us to work in isolations. We have policymakers who feel they are doing their own thing, and so they are working independently. We have researchers also who are also working independently. The thing is, we need to realize that we are seeking to address the same problems, the same health issues, and so we are better working together to address these issues. As a country, I think honestly, and that's why Dennis was talking of the way we have been having budget cuts on the funds that are meant to go to research. And in most cases, we have to rely on funds actually from development partners, who actually at times end up actually influencing the priorities that we are going to be researching about. We need to find a way of creating a need and a better utilization of research in our country. We build capacity to do the research, but then also to utilize those findings in the policy-making process and the practices that we are seeing.
Yeah. Maybe
if I may just before you interject, I am thinking I have seen every other government department ministry have a 5-year, 10-year strategic plan.
Yep.
And I've been part of those processes, and there are many consultants, professionals, stakeholders that actually input into these things. So it is not a purely research non-driven exercise. And I personally know that in many ministries, if you call the officer in charge of livestock and they're in charge of goats, they'll tell you all the diseases goats have, where the goats are, where they're coming from, what breed, what color, and which Maasai has them. The information is there. My question to you as ideal researchers, now not just on the medical field, but that ideal part, Africa is rising. Vision 2030, Vision 2050 there, Big Four agenda here, what's that thing called? Bottom-up economic transformational agenda, BETA, right? My question is, we keep talking about an African renaissance. Yeah. You guys keep talking about the ideal strategy to inform leadership and research. My question is not just whether the research is applied, but as researchers, you're key drivers for us to achieving these visions that we want to have. Because if you look at India and what it did with pharmaceuticals, that was based on research. It was a decision they made. But how come and for how long will African research about our population, what our economy will be, what the free trade area will do, what is missing between the thinking and the living? Because we're not living what these big research things say.
Yeah.
I'm sorry for stepping out of the medical
So I think the weakest arm is coordination and collaboration. Locally, continent-wide. So the reason Ideal actually is very intentionally multi-situated in different countries is to enable that. So I know Jeremy and I are actually part of a group where we're coordinating, doing more cohesive, broader Africa context studies, which can then apply to multiple countries. I think maybe going back as a pathologist, and we have a professor called Professor Muse, who's actually in one of our private hospitals. And, we get a lot of equipment coming from, these other countries, who are probably, the equipment are tailored for maybe Caucasian kind of skin. And, that is a big deal for us because there's some diseases that are more prevalent to the black community and this kind of thing. And he did a study just to discover what is the normal for our blood levels in Africa. And he did some research in South Africa and West Africa and North Africa and East Africa. And you'll be surprised to learn that everything we were calling disease was actually normal.
Huh?
Yes.
Such as?
So these blood levels in Africa, what we were calling based on those reference ranges outside of Africa, we were saying, Africans are abnormal. They were actually normal once he did his work. And I think what was, in lay speak, what was abnormal? What was normal that we're calling abnormal? Okay, so what we were saying was abnormal was the hemoglobin levels, which is actually the molecule that carries oxygen that enables you to breathe and do all these things. And so we usually have reference ranges that come with the equipment, and we've never actually tailored it done normal validation in our population to determine what is normal. So what would we do? We would take blood tests in the normal community who are considered disease-free and just check what is the normal in this prevalence in this community. And that's what he did. And he discovered, our readings are actually very different. It doesn't make us sick. It just makes us different.
Okay.
Right? So coordination, looking at are our ministries even talking to each other? I think the quickest I can think about is Africa CDC, who are trying to coordinate ministries and do Africa context-specific disease programming and control and surveillance. So I think one of the challenges is coordination, collaboration, and the biggest, of course, like you did mention, is communication. Yeah, so we don't package this so that it's understandable to the layman. If I told the layman, look, if you cross the road without looking, you will die, they will not, because I've explained it in simple language. But we over complicate our language. We put it into too much context. Not everyone wants to read a newspaper. Sometimes we need to consider social media and target maybe our Gen Z with what we're trying to say. And I think it would make a difference. So that's, I think, one of the biggest challenges.
If I can say something, and you mentioned about the strategies in our government offices. And when you look at most of these strategic plans, at the end of it, you're going to see an implementation matrix. However, when you look at what is truly happening practically, we have very low implementation of some of these strategies that have been put outside there. And in addition to even that low implementation, we have some of those that are implemented in a way that they are catering for the interest of some of these few implementers. We have diverse interests of the stakeholders who are involved, and at times these interests are not aligned to our national goals, to the goals that we have as a continent or even as the East African community. So there would be need, I think, in my view, to cut these personal interests or the stakeholder interest and make sure that we prioritize our national goals, where we want to be by 2030, or maybe the agenda, Africa Agenda 2063. We prioritize that and we make that as our main focus. Yes, we have this implementation matrix, but I think beyond that, we need to go to the ground totally and implement this sufficiently. That's all I would say.
Just to add on, I think sometimes also our planning is not very good. I realize in Kenya, we have amazing documents, but we don't think through how to transition where we were to where we want to go. We don't think about what are the resources, what does it take, what is the communication, what's the first step. And so we end up having this staccato and then we run into problems as opposed to trying to figure out how do we transition this smoothly. In the research setting, whenever we're doing research, we'd start by doing what we call a pilot. So instead of overhauling the whole country, we're like, okay, let's go pilot in a small village in Kisumu, figure out what are the issues, can we troubleshoot, can we figure that out, or this one we can do nothing about and let it be. But in the bigger scheme of things, the research makes sense.
Okay.
So figuring out how to transition well.
Just a quick one. There's in Kenya, we say we have influencers, and they're not the ones who dance on TikTok. The biggest influencers are politicians. and I'm wondering, yes, there's the research that is done pre-elections. how much access do you have to the politician? So let's take that village in Kisumu where you've run a pilot or done a research. How integrated is the MCA? You know, how integrated is the village elder? Because I find there's a very big difference between government and politicians in this country. They're usually in different headspaces. Is there an outreach to the political class who end up becoming ministers, etc., to be able to make research-based decisions?
Yes, absolutely. I think you'll be surprised. For example, Kenya has implemented what you call the Facility Improvement Fund. So this is a bill that came into place that all counties are tailoring for their context, where the facilities are now ring-fencing funds, different percentages, and this is where the county assembly comes in, so that they can then run their own facilities. County assembly is the one that decides how that goes. So they're actually very aware. I think another thing we negate is the fact that health is actually a big agenda for these politicians. It's just that sometimes I feel sad because we've politicized healthcare. The problem with politicizing healthcare, sometimes the consequences can be quite bad. It's real life consequences. But we actually do involve them. With KEMRI, we have a lot of community engagement. The way I was explaining that, we actually go to the community before we even start the research. A lot of brochures, we do radio drives explaining what we're coming in to do.
Yes.
So that by the time you're getting there, there's no police hounding you, asking you, what are these cars doing driving around our villages, collecting information on. So we do involve them. Do we need to do better? Absolutely.
I mean, just coming off of what you were saying, Noel, that probably one of our issues, and also going to what Jeremiah had said earlier in terms of then what you do with the data that you're then able to collect. And for me, and then what's the plan and how are you actually going to implement it? And sadly, I think there's a lot of declarations that are made, but the back end is not actually thought of. One of the most famous declarations is the one that was made in 2001, where everybody went to Abuja and decided, you know what we're going to do as African nations under the auspices of the African Union? Is that we are going to say that 15% of the national budgets of all of us will go towards health. That included health research and all of this, especially in the areas of HIV, tuberculosis, malaria, because those are the things that were plaguing the continent, right? And everybody says, yes, we'll do that. They even said that we're going to do it by a certain year. Now, we know for a fact that hasn't happened. But then I wonder, even as heads of states went to Abuja and made these declarations, this was 24 years ago. What was the plan in the back end to actually have it done? There were research organizations that existed then. There were health professionals that existed then. There were ministries of health in every nation that attended that existed then. But if for such a delicate and wide declaration in this case, the thing is even called a declaration, and there was no implementation metrics for it. That's why 24 years later, we still don't even have that.
Absolutely. So I think the countries needed to fall back and figure out the how. And the how would mean a staggered phase-wise approach. If even every country said, you know what, we'll take it up by 0.5% per year, that would have been good, 25 years later. I think, like I said, our transitions, our planning, sometimes I think that's what would have ideally have been on the back end. I think, they make these declarations and COVID happens, so now we have to switch all this into this crisis management.
But imagine if that was done and then COVID happened, you wouldn't have that problem.
So I think it would have been better managed. So I feel like a lot of us say things, we struggle with how to get it done. And then we don't even, this is where you'd require multi-stakeholder, because it's the community, it's the resources that has to be reallocated. So where do we pull away from to put into healthcare? Because, at the end of the day, nothing is free. A lot of... I say it's important because, for example, in Kenya, we hear about the under 5 free vaccines. They're actually not free. That's the thing that the community doesn't know. It's the government who actually pays for it. And that's a big budget to pay for vaccines for the whole country. We're about 58 million, right? If we're saying around 15 or 20% or 30% are under 5s, that's a big deal. So there has to be planning. There has to be, thinking through, okay, so how do we then scale up? And remember, we don't have a limitless pool of funds, but how do we become more efficient with what we have? Are we wasting? I think a lot of people also don't know what they're wasting because they don't know what they have. You know, and I think that's the conversation we're struggling with now with the finance book. What do we actually have?
Yep.
So that when we're saying 4%, it's 4% of exactly what? And I think that's...
Let's address the elephant in the room. Trump made some declarations that definitely affect vaccines, HIV medications, malaria, mosquito nets, etc. As researchers, has the government mitigated against the loss of USAID, or are we still depending on Trump changing his mind, which is a possibility? He changes it every day. So what is, should Kenyans relax knowing things are okay, or is there something looming in future where someone will go for their ARVs and they'll be told Elfisaba tafadhali?
I painfully, I think we can't relax. And the truth of it is that we are not okay. Yesterday you saw we have some workers who are demonstrating and within the health sector. The famous UHC workers, they are asking to be employed on permanent and pensionable terms. And when you look at the health sector in Kenya and all these issues that we have been experiencing, and then Trump happens and this funding is withdrawn, we can't sit pretty. The truth of it is we can't sit easy. We have challenges and we need to really think of how we are going to address them. Can I say that does our government is doing enough to address them? They are trying, but I don't think it's enough for us to be able to sit back and say that everything has been well sorted and catered for. I think we have resources to be able to take care of our health, but we need to prioritize. We need to look at how do we prioritize these health issues. We need a better functioning health system in Kenya. And how do we get there? Today in the afternoon, the World Health Organization is going to be releasing their research agenda and their health priorities, research priorities for the country, for the globe. What are our research priorities as a country? What are our health priorities right now as a country? I don't think we have that clarity, both at the level of the policymakers, but then also at this other end where we are involved in the evidence that we are generating. So yes, Trump happened. We are not okay, but we need to work towards getting there to that point where we can say we can sufficiently address our health needs.
Yeah, but I think just to add on, I think government obviously are aware of it, and having interacted with colleagues in government, you do realize they need to reorganize, and they are reorganizing, trying to figure out how to get this done. Healthcare is a big agenda for us. It's a big priority for us. We have a lot of technocrats, with a lot of institutional memory, who are able to figure out, okay, so how do we rearrange things so that those who are suffering from, these diseases that require a lot of support, monetary or otherwise, still continue to be cared for. So it's not that the transition is happening. A lot of planning in the background still ongoing. Yeah.
But needs to be done.
Yes.
We're talking about that when today's Standard on page 9, there's a story about crisis looms as health budget faces a 67 billion cut. And we keep having these discussions of we need health to be a priority in this country. Unfortunately, there's a serious disconnect. My last question will be, what reforms do you think need to be put in place, both from the government or the academia, to institutionalize some of these research decisions in your field?
Yeah, so for example, we need to do research around healthcare expenditure and budgeting, and having the economists come in and healthcare specialists come in so that we're able to crunch numbers and figure out exactly what we're doing. I think the biggest problem, and I still maintain, is wastage. We don't know what we're losing. For example, if we have vaccines that are expiring in Wajir, why can't we figure that out? Who has a database showing how many vaccines we have there that are going to wastage, and then use supply chain and Ministry of Health, because if Standard is able to move this newspaper to Western, it can move it back.
Yes.
Figure out how to get these vaccines from Wajir to Kisumu, where they're needed and can be consumed, right? So are we having budgeting cuts coming up? Yes. Do we need to think through that? Absolutely. Is it a problem? Yes, it's going to be a problem. Yeah. And then, of course, we are also having teething issues with the many other new policies that and bills that have come into place,
Indeed.
including SHA. But I think sometimes I also want to give a bit of grace. Sometimes you have to give something time to get to work.
To open up.
Yes, to open up and to work.
And it's good that we can talk about them and necessary. And I mean, it seems like everything we do discuss necessary for us to have that out into the open. And so we thank both of you for being here this morning to help us do that. And our friends, from Kemery to constantly have these conversations, because the work that is being done is too important to not talk about. Jeremiah Nganda is an ideal postdoctoral fellow at the Strathmore University, and Noel Orata, an ideal PhD fellow at Strathmore University. Thank you so much for being here this morning.
Thank you for having us.
This is the Situation Room, the only way to start your day.